let's build off of Dr. Luckenbau's presentation with session 2, understanding your pathology report. I think there were a lot of questions about pathology grading and, on kidney cancer. So we are joined by Dr. Cody Craig, a genitourinary pathologist at Vanderbilt University Medical Center in Nashville, Tennessee. So please see his full bio in the program section of the meeting platform. Remember to add any question about this presentation like you did for Dr. Luckenbau in the question box on the right side of the screen. I would welcome Dr. Craig. We see a blank screen. Hopefully we can see you as well and hear you too.
Hello, everyone. I apologize for all the technological issues. So my name is Cody Craig. I'm a genitourinary pathologist at Vanderbilt University. I specialize in the entire genitourinary tract from kidneys through the ureters, bladder, including the male reproductive system. So of course, today I'll be talking about kidney cancer and specifically how to kind of interpret the pathology report that we issue out. And so I'll start off here. So I would like to just briefly go into the role of the pathologist in the medical system because it's relatively poorly understood even among other healthcare workers. So the general description is that we are involved in the examination of body tissues, and that's in any capacity. So this includes like when you get your blood drawn and it gets sent to the lab. So like a CBC or checking your calcium, things like that. That's part of chemical pathology. If you get a blood transfusion, that's part of our transfusion medicine service. If you get a blood culture, lung culture, something like that, that would be our microbiology department. The thing that most people are probably familiar with are autopsies, especially that's what you see on the news, forensics cases, and that would also fall under our purview as well. And even though I am certified in all of these areas, I specifically work in what we call surgical pathology. And so what we do is we work very closely with the surgeons. We take the tissue that they give us, we will look at it with our hands, with our naked eye, and then we will send that off to be processed, and then we will make that into glass slides to look at under the microscope, and then issue a report based on those slides that we receive. And so that report is kind of what we will be discussing here. This is an example of a report that you may receive from a pathologist, specifically having a kidney removed. And I'll break down what each individual part means as we go. So even though it comes last in the report, usually, the first thing that we do as pathologists is what we call the gross description. And this is when we are physically holding the kidney or whatever tissue it is in front of us, and we are making observations on it. I will go ahead and warn you now, there will be pictures of actual human kidneys that we have processed. So if you're squeamish, you can look away for a moment. Okay, so each time that we receive an organ from a surgeon, we follow the same similar steps when we're examining it. The first thing that we do is measure and weigh the tissue as a whole. And then we will measure each relevant individual component. So for example, when we receive a kidney, we will take the whole specimen and do those weights and measurements. And then we will check out the kidney itself and do the same with that. We'll look at the ureters, and then we'll look for any other organs that may be present. So like adrenal glands or a piece of liver or whatever else happens to be along for the ride. Before we make any cuts with our blades, we will cover the outside of the specimen in ink, which will be important later. And then we will cut the kidney in half to see inside. So we kind of do make it look like a butterfly. So we make one slice down the middle and then fold it apart. And then once we have it open, then we look for any tumors that may be in there. We measure those. We see how those tumors relate to those other structures that we checked out earlier. So is that tumor close to the adrenal gland? Is that tumor close to the ureter, et cetera? And so once we've finished our examination, we will take a few small pieces of tissue about the size of a dime, and we will submit those to be processed. And that's what we will actually be looking at under the microscope. And so these are some examples of a normal kidney that we would be seeing during a gross description. So this first picture is a kidney, and the structures have been removed from it to make it looks relatively similar to this graphic here. You see, this part is where the blood vessels come in and out, and then the ureter will also attach right here, and you can see it compared to the schematic next to it. And so this picture is sort of the first thing that we do when we receive the kidney. So we've already started the process of examination here. And you can see the outside is entirely covered in this black ink, and it kind of makes a mess. But there's a reason for that, and we'll talk about it in a moment. And so you can see this long structure coming off. So that's the ureter. And then it kind of starts forming up here. So this is kind of where the kidney starts draining into the ureter, and then it travels this way. And so this dark brownish, reddish color on the outside, that's the actual functional part of the kidney. And then you see this yellow material is fat. And so you see there's fat on the outside of the kidney, but there's also fat on the inner portion of the kidney. And I will just point out, so when we cut these kidneys in half and we kind of butterfly them out, we cut them, we make our slice at the inner side of the kidney. And so when we pull it apart, the inner side of the kidney is on the outsides, so here and down here. And then the outer part of the kidney is actually down the middle here. And so all of these structures, it's important for us to look at so that when we find a tumor, we want to make sure it is staying in the kidney, or to see if it has escaped from the kidney, gotten into this fat, gotten into this fat, gotten into the ureter, gotten into the vein, etc. And so that's why the gross description is very important. And so once we make the evaluation, we will take little pieces of that and put it under the microscope, because even though it looks like it may be involving the fat or involving a vein or something like that, we need to see it under the microscope to prove it. We need microscopic evidence of that. And so we always measure our tumors in 3 dimensions. That has a big impact on the tumor staging. I know Dr. Luckenbaugh talked about that briefly in her presentation. So especially in the early stages of the tumor, so T1, T2, those are very heavily based on the size of the tumor. And so having a good, accurate measurement of the tumor is very important. So you can see these are clearly different size tumors. This one's quite large, and it's distorting the entire half of the kidney. And this one over here is relatively small. And we can get some idea also about the different colors, about what kind of kidney cancer it might be. So this is kind of a reddish, almost mahogany color, and it's got some bleeding into it. So we can kind of guess what it might end up being. And then this is kind of a pale tan color, also has a lot of bleeding in it. So this is probably a clear cell renal cell carcinoma. But again, we will prove all that when we look at it under the microscope. And so this is how we assess the tumor and its proximity to important structures. So our ultimate goal here is to see if the tumor is still confined inside the kidney or if it's escaped. So this left picture shows a tumor that it looks like it has escaped into the fat of the inner portion of the kidney. And so remember, the inner portion is actually on the outside when we cut these. And so it looks like the tumor is inside the fat now. We want it to be confined to the kidney. And so we're very suspicious that this one has escaped from the kidney. Again, we will look at it under the microscope to verify that, but it's very suspicious. Versus this one, again, this is the outer side of the kidney, and this tumor is kind of bulging into that fat on the outside of the kidney. It's very common that we only have bulging out and it's not truly invasive. So that's why it's so important to see it under the microscope, because if it's not actually out of the kidney and it's just bulging, then that would downstage it. So it's a very important distinction. Okay, so now that we've made a final diagnosis, we've taken the tissue, we've processed it, we've looked at it under the microscope, and we have the glass slides, so we can finally give a diagnosis. So the final diagnosis is basically just a brief summary of the important findings that we have in our case. So each pathologist has kind of a different way of writing these up, but there's the same general idea each time. So we have what we call a top line. So that's the organs that were removed. So right kidney, or right adrenal gland, part of the liver, and then the procedure that was done. So a radical nephrectomy. And then we have the overall diagnosis. So in this case, it's a clear cell renal cell carcinoma in this example. And then oftentimes we will include a comment, and then we'll mention the synoptic report. We'll get to that in a second. So comments, they're used in different ways for different pathologists, but in general, we usually will talk about other extra testing that we did to confirm our diagnosis. So when we make a slide out of a piece of tissue, we actually stain that slide with red, a version of a red and a blue ink. And we do that for every slide all the time. But sometimes we will dip that slide in a special colored ink, so a brown staining ink that specifically only stains certain things. And that's what these are. So these are stains only for very certain markers on cells. And that tells us, if it's a kidney cell or what type of kidney cell. So we use combinations of these to help our diagnosis or confirm our diagnosis. And then we leave these comments so that maybe if another pathologist reviews this case, they'll see what we did, so they don't have to repeat it, or maybe they agree or even disagree. But that's a lot of times what we use comments for. Additionally, that's also a way for us to convey to either the patient or the surgeon or the oncologist other information they might need to help manage your care. So that leads us to synoptic reporting. And so this section is largely what drives the management of the tumor. So synoptic reports are summaries that include all the information that's been shown to reliably affect treatment and prognosis. So these were made by one of our national organizations using all of our current up-to-date research, and they're standardized across the entire country. So no matter where you had your surgery, no matter which pathologist is looking at your case, all the same information should be in there. And so each organ does have its own different synoptic report because there are different things that are important for each type of cancer. So say if you were to read a pathology report on lung cancer, it's going to have different information on here because not all of these things are relevant to a lung cancer, and vice versa. And so we'll go through each one of these categories briefly to discuss like what these things actually mean. Specimen, we've kind of already talked about. It's pretty straightforward. It was a right radical nephrectomy. That's what your surgeon performed. So we'll get right on into the tumors section. So the first header in the tumor group is focality. So unifocal, multifocal, it kind of speaks for itself. So if there's a single mass, like in the earlier cases that I showed, that would be unifocal. And then if you look at this case, you see all these little holes, almost like Swiss cheese. We use a lot of food analogies in pathology because it's really gross. So this person has really long-standing unhealthy kidney. So they have basically kidney failure probably. And if you look closely, you can see these pale tan nodules that kind of stand out from the background. Every one of these are all little renal cell carcinomas that are just popping up all over the place. And so we would consider that multifocal disease. Tumor size, again, is pretty self-explanatory. When it comes to multifocal tumors like this case, we try to find the largest tumor that we can see, and then we will take the largest measurement of the largest tumor, and we will use that for our staging purposes. So also under the tumor category is histologic type. And so I just mostly wanted to put here to show you how complicated it gets. There are many, many different kinds of kidney cancer, and this list is not even comprehensive, but it does cover the currently accepted names per the organization that created all these reports. This list is constantly being updated, and so as we're learning more information, getting more research done, we're adding or subtracting from this list. And so the type of tumor here will give your surgeon, your oncologist, a lot of information about its behavior. For example, some of these are more likely to metastasize, some of these are more likely to spread locally. Some of these are more likely to come back. Some may have a genetic component, so you may need to be treated or look to get imaging for maybe you're at risk for other tumors. So a lot of information can be gained from the histologic type. And that's probably one of the most challenging parts of what we do, is to try to differentiate different tumor types from one another. These are just pictures of what we are looking at under the microscope. So, everything is stained in a hint of bluish and reds. So that's our world is, we often say it's in blues and reds or blues and pinks. And so every tumor can be kind of described in that way. And then we use those extra testing to make it other colors to help differentiate them. So if you look down here, this is a normal kidney. And there's the functional part that actually does the filtration, are these little round, darker dots. And then all these other things in between are tubules that basically moves the fluid in and around. And so different tumors come from different cells here. And so that's kind of why there's many different types of kidney cancer, is because there's many different kinds of kidney cells. These we won't have to go over the different subtypes, but just to know that they look different, of course. But so here's some more examples. There's enough overlap that it can be challenging to differentiate one tumor from another. And these are the most textbook examples that I could find. So they don't always look perfect, unfortunately. So for example, like this one has clear cells, but it's not a clear cell renal cell carcinoma. It's a completely different kind. So that's why we have to be very careful and why it might take a few days to get the reports out. And for example, these look pretty similar. These are just closer together than these, but the cells look the same. But this one's benign, this one's malignant. So again, it can be complicated. So histologic grade is based on the cell nucleus and the nucleolus. So the nucleus are the darker round circles. And then the nucleolus is the smaller, even darker dot in the middle. And so you can think of it like the nucleus holds the information that the cell uses to grow. And so as the cell becomes more abnormal or more aggressive, then it gets bigger, it looks worse. These nucleoli, the nucleolus on the inside, it gets bigger and easier to see. And so that's kind of how an easy way to look at it. And so we will grade these from 1 to 4, with 1 being the least abnormal, almost looks like a completely normal cell. And then grade 4 would be the worst. And so this is an example of a grade 2. So we can see the nucleoli, they're relatively small. And then if we go over here, they're big. They're getting a lot bigger. They almost even have a red hint to it. So we call that cherry red. And so this is probably what we would consider a grade 3. And then this one, even though it is zoomed out, it's even worse. So not only are the nucleoli big, the nuclei are very abnormal shaped. We like them to be round, or at least roundish, but these are getting very abnormal. And so this would be a 4. And so when they become grade 4, they're very concerning because depending on the tumor type, they may be less responsive to chemotherapy. They may be more likely to spread to other sites. So grade 4s it's important for us to be able to recognize that. And sometimes it can be very focal. So if we call something grade 4, that doesn't mean the entire tumor is grade 4, but we base it on the worst area in the whole thing that we could find. Because really, that's what's going to be the aggressive part of the tumor. That's the part that's going to be spreading, or that's going to determine how it behaves. Okay, so I mentioned earlier that when we are looking at kidneys grossly, we're looking to see if the tumor has escaped from the kidney. So I just wanted to show this as an example of, so this area is normal kidney. This, of course, is the big tumor. In this area, this white clear area is fat. So fat doesn't get processed, so it disappears on our slides, but we know that's what it is. And so we are trying to see, is this tumor in fat, or is it just bulging out? And in this case, it looks like it's just bulging out, so that would not be a higher stage. But if we compare it to this picture, so this whole area is tumor, this white area is the fat, there's a little on both sides, but then there's tumor that is on the other side of fat, and it is attached here. And so this is tumor that has escaped from the kidney, and so that would be an upstage, a higher stage kidney cancer. And now if we look here, so again, this is when I talked about kidneys, tumors escaping from the kidney and into the fat. It can do it on the outside of the kidney, but it can also do it on the inner side of the kidney in that fat. And so that's what's happening here. We have tumor, and it's escaped into this. This is fat, and it's next to the ureter, so where the ureter attaches. So this is, again, upstaged because it has escaped from the kidney. Similar over here, this is the wall of a vessel, and this is tumor that has gotten into that vessel. Kidney cancer loves to get into blood vessels. So when we see that, that again is escaped from the kidney and has upstaged the tumor. Excuse me. So one other question that the Synoptic always asks is there sarcomatoid or rhabdoid features? So we can think of that as a change in the shape, if you want. Most of the regular tumor cells are kind of roundish, but when they start to look sarcomatoid, they get these flat, stretched out look. Rhabdoid can be described, it's called rhabdoid because it's like a muscle. And so it looks like a muscle cell, which gets long and really pink. So basically they just don't look like what they used to. And when this happens, it's automatically a grade 4 because these behave relatively poorly compared to the others. So it's always important for us to go over those and see if we can find any grade 4 sarcomatoid or rhabdoid areas. All right, so margins. So this goes back to when I mentioned why we ink the outside of the kidneys when we first receive them. And so resected kidneys are always covered in ink at the time of gross evaluation. And so that is our visual representation of where your urologist made the cut in your body to remove that kidney. So you can think of it wherever a knife touched, we put ink on it. And so we do that because if there's tumor touching that ink, then we have to assume that there may be some tumor that still is left inside. And so that's what we call a margin. And we use ink because that can be seen under the microscope. So we see this black ink on the outside edge of the tissue right next to the tumor here. And so we can actually measure how far the tumor is from the ink and see how far that margin is away from the tumor. Okay, last category that we have is lymph node status. So lymph nodes, they're not always present, so it may be blank. But lymph nodes are often the first place that a tumor will go to once it spreads, but it really depends on the type of cancer. Kidney tumors are less common to do that than some of your other malignancies, but they do go there on occasion. And so this bottom picture is what a normal lymph node would look like. So these dark blue cells, if we were to look really closely, they're perfectly round, and those are lymphocytes. And then we can compare it to the top picture where there are many lymphocytes still up here in the top half. But this area, you can see it looks very different. It's much lighter. It's very pink instead of dark purple. And so this is actually a big deposit of tumor. So this would be considered a positive lymph node, and this would be considered a negative lymph node. And so what we do is we just count how many nodes there are. We count how many are positive, count how many are negative, and then we will use that in our staging. Okay, and so now that we have all that information, we can finally classify that tumor. So, when talking about cancer, you often hear people say things like stage 1 cancer, stage 4 cancer, etc. So as pathologists, we have our own staging system. So that's what the little P in front of the PT, so that's pathologic, and then T is for tumor. So the pathologic tumor staging. And treatment, of course, will vary depending on this pretty heavily. And so these earlier stages, so stage 1s and stage 2, it pretty much entirely depends on the size of the tumor. And all of these are only in the kidney. So none of these have escaped. So if it has escaped from the kidney, then it automatically at least is a T3A. And then depending on where it goes after it has escaped, that's what affects 3A, 3B, 3C, or 4. We also give a stage for lymph nodes. Like I said before, there may not even be any lymph nodes at all. And so if there aren't, we'll say this is not assigned. That's relatively common. We often don't get lymph nodes with kidney tumors. So if you see not assigned or not applicable or unknown, don't panic. It's perfectly normal. If there are any lymph nodes at all and they are negative, we'll call it an N0. And if there's any lymph nodes at all that are positive, it's an N1.